بسم الله الرحمن الرحيم. السلام عليكم جميعا. في البداية I'd like to express my gratitude to the organizing committee and scientific committee with special thanks to Dr. سامح المراغي. زي ما الدكتور حسام قال يعني it's a success from one year to the other and it's growing success الحمد لله. I'm going to talk today about a very important topic. We usually overlook it in our ICUs. We go behind bacteria and we overlook the fungal infections. In the general ICU practice, there is increased incidence of invasive fungal infections. This is related to changes in the hosts, or changes in the treatments, or changes in the outcomes. For the host, there is medical progress in medicine over the last 50 years, and so we are having more aging and sicker population on life-sustaining therapies. There is changes in treatment allowing hematopoietic stem cell and organ transplantation. There is intensive chemotherapy for malignancies, and there's prolonged survival for HIV patients. There is direct effect on mortality and the outcomes by the treatments, and there is indirect effect on ability to treat by the growing treatments. Today أنا مش هتكلم على patients who are immunocompromised. I don't have time for this. I'm going only to talk about general ICU patients, which are not including transplant patients or hematology oncology patients. In the general ICU patients, the invasive fungal infections in high-risk patients is compromised mainly of candidiasis, which gives us about 40% of the patients and 15% for the aspergillosis or invasive aspergillosis. So my talk today will concentrate mainly on these two organisms, on the invasive candidiasis and the invasive aspergillosis. As we all know that the invasive candida, or the candida generally, is a harmless inhabitant of the skin and mucous membranes of all humans. And the normal immune system usually keeps these organisms outside the body surface. So the main defense against the candida is because of the skin and mucous membrane integrities and the presence of normal bacterial flora. And that's why if you give a broad spectrum antibiotics for a long time, you affect the normal bacterial flora. And that's why you invite more and more candida infections. The other defense mechanisms against candida includes phagocytosis, mainly by the polymorph nuclear leukocytes. And so if you have neutropenia, you are having more and more invasion for the invasive candidiasis. And for the skin and mucous membrane invasion, you prevent it by the T cells, CD4 cells. According to the IDSA, there are at least 15 distinct candida species. The world of candida, or the world of fungi, all in our nature, comprises about 100,000 species. That affects the species that affects the humans is only 100 species. From these are 15 distinct candida species. 5 of them are the most common pathogens that cause the invasive candidiasis, which are the Candida albicans, glabrata, tropicalis, Prapsolosis, and Crocii. Each of these organisms have its unique virulence. It has a different virulence from the other. It has unique epidemiology and has antifungal susceptibility different from the others. But as a whole, we call this the invasive candidiasis. According to the estimates by the United States, in our region, we don't have accurate estimates, but according to the United States statistics, 250,000 people worldwide every year have invasive candidiasis. Of this, 50,000 worldwide dies because of this. They are more specific for age, extremes of age, for the neonates and the elderly. And candidiasis has been cited as the 4th most common bloodstream infection in the ICUs. The distribution of cases of invasive candidiasis, 60% in the last 2 decades before, we have 60% of Candida albicans and 15% of glabrata, and the others comprise between 5 and 7%. But in the last decade, we started to have the Candida albicans less and the other invasive candidiasis from the other types, which is more. I'm going to discuss the invasive candidiasis in a case that we usually face everybody in our ICU, every day in our ICU. This is a 43-year-old male who had a stab wound to the abdomen, arrives in shock, sigmoid colon injury, with fecal contamination, has splenic laceration, he had hypothermia and acidosis, 2.5 liters combined blood loss from trauma and surgery. All the lines have been inserted, arterial, central, and catheters. He's been started in the OR by piperacillin tazobactam, 4.5 grams IV. Explanatory laparotomy and splenectomy has been done. Sigmoid colectomy and colostomy has been done. Patient receives a lot of blood products and has been kept on peptaz and flagyl post-operatively. In the post-operative course, we started to have continuous fever until the 3rd post-operative day. Still ventilated, the chest X-ray started to show scattered infiltrates. So we started to have evidence of some lung affection. Full sepsis ARCAP was sent again. CT abdomen was done to exclude any new abdominal collection, and the surgical sample came from the lab to grow E. coli with extended spectrum beta-lactamase. So the peptaz was changed into imipenem, and teicoplanin has been added to cover the gram-positives. Fever persists until the end of the day 4. Patient is still awake and lethargic. Abdominal examination still the same, no change, but we started to have unstable hemodynamics. This means the patient is going to shock with urine output which is going low. He started CVVH, continuous veno-venous hemofiltration, and the patient is still ventilated. So at such situation, do you like to assess for fungal infection, or do you like to wait for the septic up that has been sent? I think it's time now to assess for fungal infection. How? Let us go for clinical at first. The first thing you should look for the clinical signs, which is the rash at the peripheries, oral thrush, and please, for the ICU, I think it's very important to look for the white spot in the fundus, because the presence of the white spot in the fundus means that this patient is having invasive candidiasis, which usually in our ICU, we miss this a lot because nobody looks in the fundus in patients who are suspecting invasive candidiasis. We have a lot of risk factors in our patient. If you look to it, this patient has been on broad spectrum antibiotics for a long time, for all his ICU stay, which is 4 to 5 days. His Apache score is high. He's in hemodialysis, hemofiltration with central venous catheter. All of these are risk factors for developing invasive candidiasis. Major trauma, perforation of digestive tract, and major abdominal surgery. These are risk factors. Presence of these risk factors allows you to think of invasive candida infection. There are a lot of risk predictive models. Nobody talked about the risk predictive models for a long time, but in the last guidelines done by the European Society of Intensive Care Medicine and the European Society of Clinical Microbiology and Infectious Disease Task Force, they were the first guidelines to touch the risk prediction models. They said risk prediction models, because of their simplicity and high negative predictive values, should be used in identifying the high-risk patients for developing invasive candidiasis. The risk predictive models, the most common that we all know is the Colonization Index, the Candida score, and the prediction tool. All of them, again, I'm saying they are very good negative risk prediction models, but they are not good positive risk prediction models. For the Colonization Index, which you all know, I'm going to go rapidly for the predictive value of this. The sensitivity of the Colonization Index is 100%, and the negative predictive value of this is 100%. So if you have a colonization index which is low, this means the possibility of invasive infection is nearly not present, according to the colonization index. The Candida score, in our patient, we have a surgery 1 point, severe sepsis 2 points. The Candida score, when you reach 3 points, this means that you have a sensitivity of more than 80%, and you can depend on it for the negative prediction, not for the positive prediction. The third one is the clinical prediction tool, which is the presence of 1 of 2 of systemic antibiotic and presence of CVC, and the patient has both of them. This gives you also a good negative prediction, which is more than 90%. If you have the clinical prediction tool, which is low, this means the negative predictive value of this is more than 90%. We have also laboratory diagnosis, but unfortunately, if you have a patient in a study, they showed that the autopsy-proven invasive candidiasis, only 50% of these patients had a positive blood culture. So we have definitely proven by autopsy patient invasive candidiasis, but the blood culture came to be only positive in 50%. So we cannot depend on blood culture only for diagnosis of invasive candidiasis. Other lab diagnosis, whether molecular methods, serological methods, and histopathological methods, just to mention here by the 1,3-beta-D glucan assay, it's also a good negative predictive test, but not a good positive predictive test. So we are in a diagnostic dilemma actually in these patients. Clinically, we don't have a lot of specific signs, Radiology is only helpful in Aspergillus. Cultures, as I said, low yield and longer time to get. PCR assay is not informative. 1,3-beta-2-glucan assay is not informative. Galactomannans for Aspergillus. And the PNA fish is only for albicans and glabrata. So in this situation, we will depend mainly in our risk prediction models, on our clinical signs, and on our risk factors. And in this situation, I think it's very important to consider fungal infection in this situation. And if you consider, now, would you like to start antifungal? Yes, I'd like to start antifungal, especially if I look to the mortality, crude mortality for the invasive candidiasis in the patients is 39%, which is higher than most of the gram-negative bacteria that we are always fighting for in our ICU. The guidelines done by the IDSA in 2016, which is, to my knowledge, is the latest guidelines done by the Americans in this situation. They said that the empiric antifungal therapy should be considered in critically ill patients with risk factors for invasive candidiasis and no other known cause of fever, and should be dependent mainly on clinical assessment of risk factors, surrogate markers if you have, and cultures from non-sterile sites. Empiric antifungal therapy should be started as soon as possible. You should not wait if you have the above risk factors that I've been mentioned, especially if you have clinical signs of septic shock. The European guidelines done in 2019 were more conservative because they are now thinking of resistance to the antifungals. So they said only you should consider empiric antifungal therapy in patients with septic shock and multi-organ failure. In our patient that I just mentioned, we have both, going to septic shock and the patient has multi-organ failure. Or if you have more than one extra digestive site outside the digestive tract with proven Candida species colonization. And they said, please not to start empirical antifungal therapy in patients without septic shock or multi-organ failure if you don't have a surrogate marker or culture which is positive. This is they are thinking now of the resistance more than the Americans. Concerning the surviving sepsis campaign in 2021, it's the same recommendation, nearly like they started the same recommendation since 2008. In 2008, they said if a Candida infection is suspected, you should start treatment before a definitive diagnosis is made. And in 2021, they said for patients with sepsis or septic shock at high risk of fungal infection, we suggest to start empiric antifungal therapy over no antifungal therapy. Why they are so eager to start the antifungal therapy? Because there was a big two studies done in 2005 and 2006. They showed that if you start the antifungal therapy very early, in the first 12 hours, it's better about more, if you wait for more than 48 hours, the mortality increases about 3 times, from 11% to 34% in the first study, and from 15% to 41% in the second study. That's why it's very important to start the antifungal therapy in these patients as early as possible. So now we decided to start the antifungal therapy. Which antifungal therapy are you going to start? You start fluconazole, amphobi, echinocandine, and flucytosine. In this situation, I'd like to tell you about the mortality before choosing one. The mortality for the highest mortality for the Candida cruzii is 58%, and comes after that the glabrata 50%. If you look to the susceptibility of the antifungals, you'll find that the glabrata is resistant to the fluconazole, and the cruzii is resistant to the fluconazole. So in this situation, you should choose anything else apart from the fluconazole. What did the guidelines say? The American guidelines say that the preferred empiric therapy for these patients is the echinocandine. Okay, whether it is the micafungine or the caspofungine or the anidulafungine. And you should go to fluconazole if you have an antibiogram related to your ICU. So please, in every ICU, we need to have an antibiogram specifically addressing the susceptibility of antibiotics and antifungals to decide about this. You will use the liposome and amphotericin B only if you have problems related to the echinocandines, whether reaction or something that prevents you from giving the echinocandine in this situation. The European also, they said the same. They recommend the echinocandine to be used as the first treatment option in critically ill patients with septic shock and multi-organ failure. But they said that please, if the fluconazole should be considered the first treatment with low severity of the disease. So if you have a patient who is having no septic shock or no multi-organ failure and you are suspecting invasive fungal infection, start by the fluconazole. How long should you give this patient if you give him as empiric therapy? You don't have a positive culture. If you have a positive culture, documented treatment is known. 14 days from the first negative culture. But if you have empiric therapy, it's the same. You will give it for 2 weeks and follow up the patient if he is improving or not. But the Americans say the patient who have no clinical response for this empiric antifungal therapy at 4 or 5 days do not have any subsequent evidence of invasive candidiasis after the start of empiric therapy, and all the cultures that have been sent has been negative from all the sites, sterile and non-sterile sites. So in this situation, it's better to make a down or de-escalation of the therapy, of the antifungal therapy for this patient. The European also said the same. Treatment should go for 14 days after the first negative blood culture, or for 2 weeks with the empirical. But extended therapy should be given to 3 cases: osteomyelitis, if you have osteomyelitis, invasive candidiasis; if you have septic arthritis, or you have infected or endocarditis, infected pacemaker, or ICD or VAD infections. Back to our patient. We are going now to give the patient echinocandine. The last question in my patient: would you like to remove the central line or not? Okay, yes, it's definitely by all the guidelines you should remove the central line. This is based on what we call the concept of biofilm, or the Candida biofilm. This is very important to remove the central line, and it's recommended by the 2016 guidelines of the Americans. The same for the European. They said it should be removed because they consider the central line as the source of infection in this situation. I'm not going to discuss the biofilm because of the time, but I go directly to the Filamentous fungi, which is the Aspergillus, for the purpose of time. The Aspergillus, or the invasive Aspergillus, goes to our body through 2 sites, the sinuses and the respiratory tract. From the sinuses, it goes to extension to the adjacent organs. From the respiratory tract, or from the lungs, it goes to dissemination to the circulation. For the lungs, we know that the CT scan is very diagnostic. If we have evidence of this Aspergillus pneumonia in the lungs, you will see it baseline with the halo around. The halo starts to increase by the day 4. You might find a crescent. It's not 100% of the cases you find a crescent for the patients of invasive aspergillosis. For the other invasive aspergillosis, you might have a sino-orbital disease like you see in this patient I'm showing. It might go to the brain, and you'll find cerebritis or cutaneous infection. In these 3, surgery should be considered for these patients if it is applicable. The treatment principles for the invasive aspergillosis. Just 2 minutes.
Thank you, Prof.
Reduce the immunosuppression, restore immunity if possible. Start antifungal therapy promptly, and for the antifungal therapy, and consider surgical resection. For the antifungal therapy, voriconazole comes the first line of treatment. If you compare the voriconazole to the liposomal amphotericin B, the voriconazole in invasive aspergillosis gives a survival of 70% compared to the liposomal ampho B, which is about 47%. In the last few weeks, there has been a new antifungal called suba-itraconazole that is given for the aspergillosis, and it's higher efficiency and less toxicity compared to the voriconazole. So I take home message: invasive fungal infections are mostly opportunistic. Take the advantage of breach of a host defense. Candida is the most common invasive fungal pathogen in hospitalized patients. It's part of endogenous flora, as you all know. Portal of entry is skin or mucosa. Fever is often the only manifestation. Usually disseminates via bloodstream. Early recognition and effective treatment is the key to saving lives. For Aspergillus, it's much less common compared to invasive candidiasis, but even more deadly. It's airborne. Portal of entry is the nasal passages, respiratory tract. Pneumonia, sinusitis is the usual presentation, and voriconazole is the drug of choice. Thank you very much.